All right, so we're moving into pharmacology. The first few things are kind of, I want to say, almost a BLS review. Okay, as EMTs, we're already using um, the basic principles of pharmacology, right? We understand that patients take medications and those medications affect their body in ways that we need to kind of be aware of. And we also are able to administer some medications, right? So we have, as BLS providers, about 7 medications or so that we are able to either administer or assist in administration. Um, and we should be relatively familiar with those. Okay, we should kind of know what the indications and contraindications of those medications are, because your um, drug bag is going to expand to probably about 30 to 50 medications, depending on where you work and depending on um, what your agency decides to carry. Okay, so please feel free to throw up some questions if in the middle of the if you have any questions. Um, I'm going to give you guys a little bit of homework at the end, a smidgen, not a lot, but it's just to kind of prep you for um, working through what medications are and like being more familiar with them and their indications, contraindications. But we'll get to that at the end. Okay, so okay, so principles of pharmacology. Um, Pharmacology is defined as the scientific study of how various substances interact with or alter the function of living organisms, right? So, we all have a very, I think, basic understanding of how this works. So, like, for example, if you're taking a beta blocker that binds to the beta receptors in the body and it prevents them from doing what they're supposed to do. Um, some background, right? 1938, the Food, Drug, and Cosmetic Act was a thing. Um, they kind of started giving the FDA some power. Excuse me, in regards to the FDA, we all have our concerns about what they think is safe and not now, because now it's all special interest. But that's another lecture altogether. And then 1970, they have a Controlled Substance Act. And that was when they started being like, hey guys, some of these drugs, I do have a blueprint for pharmacology. I'll give that blueprint out. um I'll do that right now. I'll do that in between the lectures, so if you guys have any questions, let me know. I'll give you the blueprint then. Sorry, I forgot to pull that off my email. So you have your Controlled Substances Act, right? So what medications are potentially abused, what medications are safe, and what medications can be like over the counter. In regards to your controlled substances, this is kind of how these are scheduled. And every once in a while, medications will be moved between one schedule or another. So, for example, really easy, low level of abuse medications are, cough medicine with maybe codeine in it. Okay, so maybe a little bit of narcotics flowing out over here. When you have a little bit stronger abuse potential, you have like your Valium or your Ativan, right? So things that people might get addicted to, but have very valid medical uses, right? So we give Valium for pain, and for anti-anxiety. We give Ativan for seizures, stuff like that. Then we have more, another level with a Schedule 3, still has some degree of medical validity, right? But also has a higher potential for abuse and addiction. So Tylenol with codeine, right? Vicodin, ketamine, a lot of pain meds kind of fall in here. Ketamine definitely falls into like the, hey, we might be abusing this. In the 1990s, there was a huge Special K issue in the UK. And then you move to where there's a very high abuse potential, right? So your fentanyl, your Ritalin, cocaine, right? Because a lot of people, they still use cocaine for nosebleeds. There's actually medical grade cocaine that you can get in some hospitals. But again, they still have legitimate medical purposes. And then you have the ones who are like, we don't think that there's actual medical uses for. They're doing some studies now, right? So marijuana is still, and LSD are still considered Schedule 1 drugs. But marijuana is used a lot for pain medication, especially in cancer patients who don't tolerate narcotics well. LSD is being used in a lot of PTSD studies in regards to trying to help them overcome improper memory integration. So you might see marijuana and or LSD moving out of Schedule 1 and into Schedule 2. But again, special interests, there's a lot of other factors at play to determine where controlled substances fall. There are 4 sources for medications. 4. You should know what these 4 sources are. These are important. These are ones that always come up. They love this question, right? So you have plant, animal, microorganism, and minerals. So plant, digoxin. Easiest example I can give you. It comes from the foxglove plant. Okay. Aspirin also can be plant derived. Just comes from willow bark. Okay. Animal, most of the time it's insulin. Okay, right? They'll take if they don't use synthetic insulin, they have insulin that they take from beef or porcine pancreases. Then you have your microorganisms, right? This is like the antibiotics, right? Penicillin is derived from mold. Okay, and then you have minerals. So a lot of your vitamins are fall into that mineral category. There's a lot of different forms of that medications can come in. We in EMS tend to hang out in the inhaler / spray, liquid, tablet sections, right? We have people give them tablets of aspirin to chew. We give IV liquids, or if you're in Nassau or Suffolk, they have liquid Tylenol on the ambulance, right? So you could actually also just ingest that inhaler, right? So a lot of different forms. If you read the box that the medication comes in, it will tell you, 1, the form, and 2, how it should be administered. Okay, so if you have a medication that's for IV administration only, you can't tell a patient to drink it. It's not going to work. So other things that we need to understand, every medication has 3 different names. So you have the chemical name, which is that long one. It usually involves hyphens and commas, a lot of chemical, hard to pronounce words. That's the chemical composition. All your nerdy chemists are the ones who use that medication name. Then you have the generic name and the trade name. So the generic name is something like acetaminophen, where a trade name is Tylenol, right? So the trade name is someone has branded it. They are saying, hey, this is our version of this generic medication. We are going to sell it a little bit higher because we're claiming it's more pure. Most of the time, medications won't have a generic name until the proprietary, whatchamacallit, there's a word for it that I'm blanking on.
It's usually a patent.
Patent, that's the word I'm looking for. Thank you. The patent, until the patent expires. So if they renew the patent, there's never a generic name. So there's a couple medications here and there that there is no generic version of because the company keeps re-upping the patent so that they can continue charging a lot of money for it. Look at them go. Patents do have a lifespan. So if the company either forgets to re-up it or declines to re-up it, then it can be released as a generic. So for example, you have Lopressor, right? It's etoprolol is the generic name. So if some patients don't know the generic name, some patients don't know the trade name, vice versa. So you just have to kind of look, and you'll have probably about 100 medications or so where you will know both of these names and be able to kind of play off each other on those. Like for example, like metformin doesn't have generic name as far as I'm aware. There are other ones with the glibazide and stuff like that that have you're using the generic names, but um, other things that you should kind of be familiar with, and you'll see this if you're doing interfacility transport or you're picking up a patient who hands you printed out discharge papers. Um, Similar sounding names, they use what's called tall man lettering. So in order to differentiate and draw your attention to the fact that it's one medication and not the other, they will emphasize like specific part of the word. So for example, this is supposed to be some dobutamine. You can see I failed to spell properly. Dobutamine versus dopamine. They do different things, similar but different things. Diphenhydramine versus diphenhydranate. Okay, they do different things. Um, if you ever start going down a deep hole of medications, these are all of the components that make up what a medication profile is. It tells you absolutely everything that you need to know about the medication. If you've ever gone to the pharmacy and picked up medications, that little insert that no one ever reads because it's an itty bitty font, this is what it's telling you. Okay, so there are patients who are on multiple medications who really should be reading these inserts because they might have an adverse effect that they're not aware of, or they might have a contraindication that they're not aware of, that the pharmacy, didn't know that they had an interaction or something like that. So these are some things that you want to be aware of. Reference sources is another question that always pops up. What are some ways that you can find out information about a medication? Easiest way is the medication insert, as I just talked about. There's AMA drug evaluations, the United States Pharmacopoeia. This is one, like just the word, this usually pops up as like a who gives you information about drugs, the Pharmacopoeia. Physician's desk reference, there is an app for physician's desk reference if you're feeling really spicy and you want to go download that and you're one of those chemistry nerds who really likes all that information. Totally available for you. The reason that we have such strict DOH like Part 800 rules about being able to keep an ambulance a certain temperature is because we very frequently do not take our medications off of the ambulance, right? Medications need to be in generally room temperature, unless of course it's a COVID vaccine, in which case it needs to be really freaking cold, right? So every medication has an ideal temperature in order to make sure that it has like a longevity of life. Okay, and it continues having the potency and the actions that it needs in order to be a medication and not just kind of like, an inert substance. This is why there are certain medications that you see that are in dark containers. Okay, so for example, nitroglycerin comes in a brown or a brown container for tablets or like a red bottle for spray because light will actually deteriorate the efficiency of the nitroglycerin. So if you have a patient who has an old bottle of nitroglycerin, or they take it out and they put it in a set, they have the tablets that they keep in their pocket, those tablets are not necessarily going to be as effective because now they've been potentially exposed to light. Okay, same thing. Amiodarone comes in a dark vial. Benadryl comes in a dark vial. Sometimes it doesn't. Depends on the manufacturer. But these are medications that need to be light secured. You'll see in the hospital there are certain IV drips, and I can't remember which medication it is right now, but I think it's one of either a vasopressor or like a nope, it's gone. I think it's a vasopressor, but it needs to be in the dark. Like so they put it in a special sleeve and they'll actually wrap the IV tubing so that it can't be touched by light because it will deteriorate and not be effective at all. A lot of parts of the ambulance may have secured cabinets. Again, this really depends on where you work, but there are very strict rules surrounding controlled substances. Most agencies, if they are running 24/7, the agencies will say that those medications need to be handed off one-to-one, and that those narcotics need to be on somebody's body, right? They need to be physically attached. Most of the time by a belt. Sometimes I know medics who will stuff the narcotics pouch in a pocket. that's not necessarily in alignment with the controlled substances policy. So like if you have somebody, yeah, etomidate is one of those. It's actually not etomidate. It's I believe etomidate does not need to. It does not need to be refrigerated.
It's dilcalizam, no?
Yeah,
Cardizem?
cardizem.
Cardizem.
Yeah, cardizem needs to be refrigerated. However, it can be removed from refrigeration and stored at room temperature for 30 days. So you'll actually see, and when you get on the ALS ambulances, look for the cardizem. I can tell you in the Jamaica buses, there's in the red med insert, there's actually a remove from truck date on it. It's dated the day you take it out of refrigeration. And I do this with my guys too. I have stickers I put on the cardizem bottle. So like they're like, hey, this one expired. I'll be like, all right, today is, June 16th, and I'll write 7/16 as the new expiration date. So you go through a lot of cardizem. There is cardizem that is not that you have to reconstitute. It comes in a powder, and then you have like a bag, and you turn it into like a drip. Those are shelf stable. It's the fact that it's constituted that requires it to be refrigerated. Great. Thank you for bringing that up. But yeah, controlled substances, you need to make sure like every agency has a controlled substances policy. A lot of them you need to sign in and out. There are some agencies where you don't carry the narcotics on you at all. It's in a locked cabinet in the responder car or in the ambulance. It depends on what their setup is. Any questions? Okie dokie. Questions that very frequently come up is knowing the difference in definition between pharmacodynamics and pharmacokinetics. Pharmacodynamics is how the medication alters the process in the body. Okay, and this is sometimes can be talked about in general terms. So if I say a beta blocker is a beta receptor antagonist, and we'll get into what that means in a minute, that's telling you how it alters the body's process. Okay, it's telling you, hey, this medication goes and it binds to a beta receptor and it antagonizes it, which means that it's being a bad guy and it's not letting it do what it usually does, as opposed to an agonist, which prompts prompts the receptor to do its normal action. Okay, so agonist stimulates, like epinephrine is a sympathomimetic. It's an agonist, a sympathetic nervous system agonist. It will trigger those sympathetic nervous system receptors to do what they normally do. Okay, so they're sitting there just chilling, like, hey, I live here. And then epi comes in, it's like, do your thing, and they're like, okay, cool, increase heart rate, dilate blood vessels, you constrict to the blood to the core, as opposed to an antagonist, right? So if you ever remember back in like 3rd grade English, an antagonist is the bad guy in the story. The antagonist is the one who comes by and says, oh, hey, I see that you're doing your thing. And the receptor's like, yeah, I'm doing my thing. I'm doing a good job. And it's like, yeah, stop that. And it muffles the response, or it prevents it from doing what it normally does. Okay, so think of the antagonists as kind of like the bad guy with the little curly mustache who then ties up the damsel and puts her on railroad tracks. That's what an antagonist medication usually does. And then you have ones that do a little bit of both, but we'll talk about those later. Then you also have your pharmacokinetics. So this is the action of the body on the medication. So how is it being absorbed? So any oral medication, right, that needs to be ingested and absorbed through the stomach is going to take 20 minutes to work because it needs to go through the digestive system, absorbed, and then to its target tissues. Any medication that's given via IV usually has about a 30-second absorption because it doesn't have to go anywhere, right? Distribution. If you have a patient who's in a shock state, right, they have very low blood perfusion to the tissues, the distribution of the medication isn't going to go very far, okay, because it needs blood to get to where it needs to go. Biotransformation. This is when that medication, especially oral medications, get changed by the liver. It's called first pass metabolism. So if you have this, medications that have a special coating or extended release, you take it, it goes into the stomach, it gets digested. From there, it gets absorbed into the bloodstream. From that bloodstream, it goes to the liver, okay? Because it's all basically that's the route that those vessels around the stomach go. They go right back to the liver. And in the liver, those drugs are metabolized. So you might have a drug that isn't active until it's metabolized by the liver. Okay, so the active part of that medication is the metabolites as opposed to the medication itself. So like if I give you, Benadryl IV, it's going to be a different composure than Benadryl that you ingest because the Benadryl that you ingest now needs to be broken down by the liver to be effective. Does that make sense? And then you also have elimination. Most medications are eliminated by the liver or the kidneys or both. There are some medications that are like removed from the body through the skin. Okay, not very frequently, but they might have like, just like to kind of sweat it off. But most of the time, medications are filtered out of the body and eliminated through the liver breaking it down or the kidneys filtering it out. You have a few medications that are also rectally eliminated, right? So they'll be eliminated through the stool. So just some thoughts. So basic principles of pharmacodynamics. We did a bunch of this already in that last slide, but we're going to talk about it again. So there are different receptors within the body, right? The body's pretty cool. It does all these different things to make it do what you want it to do. So you might have channels that permit the passage of ions. We'll talk about this a lot in cardiology, but most of the channels that you have that do the passage of ions require ATP to work. So you have your sodium potassium pumps, okay? So you'll have energy will be produced and it will help move ions across a cell membrane. Because these require energy, the gradient of the ions might not be what you expect, right? Because in most places we expect there to be equal ions because the body likes their ions that we like to be distributed equally. These gated channels keep create an unequal gradient. So like when you have potassium, right, you have more potassium inside the cells than outside the cells. So that's why we have these gated ions, because otherwise this potassium will be equal on either side of the cell. Then you also have things like a biochemical messenger. Okay, when it's activated, it initiates other chemical reactions within the cell. So this might be insulin. Okay. So then sometimes a normal cell function is maintained. Okay, so you might have, a medication that's like, hey, we're just going to keep everything going normal. And then you have a normal or abnormal function of the cell beginning. Okay, so that might be, hey, we're not going to stimulate this beta receptor. Okay, it's going to, so this is why when you have patients on beta blockers, they won't necessarily get tachycardic and shock because a beta blocker is creating an abnormal function. Oh, hey, here we go. So we talked about this already. I'm going to talk about antagonists first because that's the easiest one to talk about, right? Antagonist is a bad guy. It does not let the cell do its normal thing. So you'll see over here. Okay, so you have so if this is a beta receptor, okay, this is a beta blocker. What this does is this comes in and it's like, yeah, I'm gonna just kind of hang out here in this site. I'm gonna chill. Okay, and then you have a I'm having a really hard time with this word today. I apologize. A sympathetic nervous response, and the epinephrine is dumped into the system, right? And this comes to the beta receptor is like, hey, we need to activate the antagonist. The antagonist is sitting there going, no, 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 not in my house. And it is not able to stimulate the normal response that you're expecting. Okay. And then you might also have an agonist drug, which causes it triggers the receptor site to do what the receptor usually does. So, trying to think of a different medication that would be a good example. Not 100% accurate, but so atropine, right? So if the heart's going too slow, atropine would come, get into the receptor site, and start to speed the heart back up. Okay, it's not actually how that works, but use that as an example right now because I can't think of a good.
Isn't that anticholinergic, and that's why it doesn't work well?
Yeah. All right. So Narcan's a little different. Narcan is an agonist antagonist. So what happens is Narcan. You have narcotics. So narcotics, what they do is they bind to the mu receptors in the brain. And what they do is they antagonize it. So the mu receptors go and they start to slow everything down. When those mu receptors are stimulated, they're like, all right, cool. I'm just gonna chill. I'm gonna be extra chill, right? So that's why your respiratory drive comes down, the mental status comes down. What Narcan does is it's competitive. When it comes in, it has a greater affinity for the receptor site than whatever narcotic is, and it bumps it off. So imagine this is it takes that morphine or whatever, and it goes poof, and it kicks it right off the receptor site and settles in. So basically, it's leaving the mu receptor unchanged by sitting in that receptor site because now it's not being antagonized, but it's not being agonized either. It's just being left alone, if that makes sense.
So it's kind of neutral.
It's kind of neutral. It's just preventing it from being antagonized or stimulated in a negative way. What was the other medication that you said? I forgot. I'm sorry. Okay. So agonist medications, and this actually kind of applies to all medications. All medications have these components, right? So they'll have an affinity, a threshold level, potency, efficacy, a dose response curve, and we'll talk about that after. So drugs have an affinity to receptor sites. So we just talked about this, right? So Narcan has a higher affinity to a receptor site than narcotics do, which gives it the ability to bump narcotics off and why it works so well. This is like carbon monoxide, right? Carbon monoxide has a very high affinity to hemoglobin, which is why it knocks oxygen off. Okay, so it's basically how attracted is this drug to the receptor site. Then you have the threshold level. So it's how much medication is required to be in the system before some sort of action is initiated. So if you take, this is saying, okay, I have a headache, I take one Tylenol and it doesn't work, it's because that threshold level may not be high enough. You need 2 Tylenol. Okay, that makes sense. Potency is very similar, right? So if you have a drug that, going back to that the Tylenol metaphor, if you take one Tylenol and it knocks you take like one Aleve and it knocks your headache out, but one Tylenol doesn't, that's because one at the same concentration, that Aleve might be more potent than Tylenol. And then you have your efficacy. How is that drug able to initiate, or how well is it able to initiate or alter cell activity? So just because it has a high affinity doesn't mean that it's necessarily changing or initiating cell activity. It could be bound, right? So for example, carbon monoxide, right? Just because it has a high affinity doesn't mean that it's doing what that hemoglobin is supposed to do, which is delivering oxygen. So it has a high affinity but low efficacy. And then you have the dose response curve. We talk about this in terms of, okay, well, maybe you have a medication that needs a loading dose, or it stops working after a while. So you have to give a patient a certain amount of that medication in order to get to that point where it's efficient or has efficacy. So Keppra, for example, is one medication where in order to get a response from the patient or to treat their seizures, you give them a a loading dose. Okay, so it's like a big, massive bolus that you just dump into the patient, and then you start to titrate through at a lower rate to keep it in that range, that therapeutic index range, which we'll talk about a little bit more in depth. Yeah, just like antibiotics, right? So you need to take medication, the antibiotics, over a certain amount of time in order to get that dose to the right area along the curve. So you have some medications that are considered partial agonists. Um, so they'll attach to the receptor site and they'll initiate cellular activity, but not quite as much as you would expect. I don't think that we handle any partial agonists in EMS. I'll have to look into that a little closer. I'm not sure off the top of my head. So on the other end of the realm, we have antagonists. And we have competitive and non-competitive agonists. So competitive agonists, like this is your Narcan. This is why after you give a patient Narcan and it bumps the morphine or narcotic off of the mu receptors, that you can't just leave the patient, because after 20 minutes, its efficacy and affinity starts to diminish because it has too low of a dose. And if the narcotics outlive it, then they will rebind to the receptor site and cause the patient to go back into respiratory distress. So competitive antagonists are temporary, okay? As opposed to non-competitive agonists, where they will bind to the site and never let go. Okay, this is the problem with like barbiturates. This is why barbiturates fell out of favor, because they are non-competitive. So once they bound to that receptor site was done for. Okay, the body would have to create new receptor sites in order to have effect again. Okay, any questions?
Wait, non-competitive means there's no antidotes?
There might be antidotes, but those are also very, very, it's very hard to get those medications off. It really depends on the medication. Um, but yeah, for the most part, what happens is it binds to the receptor site and it doesn't deteriorate like the same way other medications would. It has a very long half-life, to the point where like the medication's half-life outlives the life of the receptor site, because your receptors are always being replenished. Some receptors are replenished faster than others. So once that receptor has a non-competitive antagonist boyfriend, they're never breaking up, as opposed to over here where it's a Taylor Swift song. So we have other medications that have like other effects in the body. Antimicrobials, for example, like anything that you take for an infection, that doesn't work on a receptor site. It actually works on the cell wall of the bacteria or whatever is attacking the body, right? So if it's like an antiviral, it'll attack the RNA. But the antimicrobials, antibiotics, don't act on our body. They work on the cell walls of the specific bacteria that they're trying to kill. Chelating agents will actually bind to heavy metals and help remove them from the system. So if you have somebody who's got like a heavy metal poisoning, it will bind to that heavy metal and turn it to an inert substance and allow the body to clear it. And then diuretics, which affects the kidneys and influences how we reabsorb sodium for the most part, and or potassium. Sodium is usually the easier one to affect, because with sodium follows water. So if you're excreting more sodium and or potassium, you'll also get rid of more water. So that's how those work. A number of different things will affect how well medications will affect the body. So first of all, the dose, right? So if you're taking a very low dose of a medication, it's not going to be as potent, potentially as potent as a medication you have a very high dose of. Okay, so like if you look at patients who are taking high blood pressure medications, those who have, who are taking maybe carvedilol, that one is usually they start you out at a really low dose because they'll titrate it up. for, you know, to hit a target blood pressure range. Age also has an impact. Okay. So you might have an older person who doesn't have as many receptor sites, the medication might not be as effective. The patient who, if it's a fat soluble drug and the patient is older and has more fat as opposed to muscle tissue, that drug might linger in their system longer. As you get older, all of your elimination functions start to shut down. Your liver's not as effective, your kidneys aren't as effective, so that drug again might linger longer in the system and have a greater effect. Same thing with weight. We talked about that. There's fat soluble drugs. A lot of medications are also weight based, especially you get into your vasopressors. Like dopamine, for example, is weight based. So if you have a large patient, you're going to need to give them more medication. The environment, a patient who is cold, the medication won't be as effective because the blood's not circulating in their system effectively enough, which means it's not getting to the target tissues as easily. Genetics, there are a handful of people or a group of people who can take Plavix and have zero blood thinning effect, because they have an enzyme that actually completely denatures the medication. So you can be on a Plavix therapy after a stent placement, and it'll just break it down, and you won't end up getting any of the benefits of that blood thinning that you would as from a different medication. Christopher Lopez, did you just fall down a well? Are you okay?
Don't fall asleep.
No, I'm good.
Sounded like you fell down.
I'm
I think you had
waiting
1 or 2 cavities.
for the alternate side parking to like leave
Oh,
upstairs.
Gotcha.
You know what I'm saying?
I do. Don't get those tickets. They're expensive. So pregnancy, right? There's some medications that pregnant patients should not be taking, or can't take, because it might influence fetal development. Psychosocial influences, right? Patient might be taking a medication for psychiatric concerns, might not be taking the full dose because they can't afford it. Insulin, same thing. They might be on an insulin regimen, and they have psychosocial impacts that won't allow them to take their insulin as necessary because maybe they can't afford it. Basically, when we're giving a medication, what we want to see are therapeutic effects, right? Patient has high blood pressure, we give them a medication. The therapeutic effect is that it's bringing their blood pressure back to a normal range. Excuse me. Other issues. This is a big one. You should understand the difference between difference of adverse and untoward effects and what that kind of means, which is a effect that you shouldn't. The patient it's a negative effect. Okay, right? So, patient is allergic to whatever. I don't know. Pick a medication, and they end up getting an anaphylactic reaction. Right? That's an untoward or adverse effect. I'm going to bring this one up. Patients on calcium channel blockers could end up with an idiosyncratic, I'm going to bring it over here, an idiosyncratic and also adverse effect where they end up having angioedema secondary to a calcium channel blocker, or sorry, ACE inhibitor, wrong medication, ACE inhibitor. So they could be on the ACE inhibitor for 1 day, they can be on that ACE inhibitor for 10 years, and all of a sudden their airway starts to swell up. Epinephrine will not have any effect on it. Okay, it's this weird idiosyncratic being like, we don't know why it happens. We kind of do, but we don't know why. Some people have that issue while others don't. And it's a negative effect because it's very, very similar to an anaphylactic response without the anaphylaxis. Cumulative actions, repeated doses means the medication might get stronger and stronger. Okay, so this is really important in your patients who are taking Coumadin. Okay, they may have a cumulative action. So if they take, you'll see Coumadin dosage is really weird. So you might have a patient who takes 2 milligrams 1 day, 5 milligrams the next day, because they're trying to keep it in this careful dosing range where their INR, or their blood, how thin their blood is, doesn't go too high where they bleed out, and doesn't go too low where they don't have the benefits of the blood thinning. Okay. Synergistic, one medication plus another medication makes a more potent medication. But this is like multiplicative, where so like one times one equals 3, whereas summative is 1 plus 1 equals 3. Okay, so this making it more potent. There's some medications that they give together to actually get a synergistic effect. So like vasopressors and stuff like that, they might tweak some of the medications to kind of increase blood pressures and stuff like that. So a therapeutic effect is where we're aiming when we treat a patient. The problem is every medication has what's called the therapeutic index. And this is based off of half of the population when they initially do the studies. And this is why some medications have a hard time getting through the FDA, because they might be more toxic than therapeutic. So basically what happens is you have what's called the therapeutic index, which lives in between the therapeutic effect and the toxic effect. Whereas 50% of the population who take this medication at 5 milligrams have a therapeutic effect, and then 50% have a toxic effect. So that means that maybe we're going to give this patient 3 milligrams or 4 milligrams. Medications that have a very wide therapeutic index are considered very, very safe. Okay, because it's like Ativan, for example. You'll see this in the hospital. They're like, all right, give him a milligram. That didn't work. Give him another milligram. Give him another milligram. Give him another. And they just keep giving the medication because it has a very wide therapeutic index. It's hard to overdose on benzos. Other medications such as Coumadin or lithium, I believe, have a very narrow therapeutic index. So they have to carefully monitor these patients to make sure that they're not in the toxic range, or that they haven't, or the dose is not so small that they're no longer getting a therapeutic effect. Okay, so that's just something to keep in mind. Most of the medications that we give have a relatively broad therapeutic index, on the dosage that we're giving. So all the stuff that we give is relatively safe. Any questions, thoughts, concerns? Bubba just popped up in the chat and I didn't see it. Okay.
Says just like antibiotics.
Yes, antibiotics. Yeah, exactly. Very relatively safe, very broad therapeutic dose. They all have, a standard dosing that is good for the majority of the population. So yeah. Everybody, to a certain extent, most medications also you can build a tolerance up towards, because your body does a number of different things. So first of all, your body will downregulate. So if you're taking a high blood pressure medication or a beta blocker, your body will be like, hey, we're just not going to make as many receptors. Or it will upregulate where it makes more receptors, so that beta blocker needs a higher dose. It depends on what kind of medication it is, right? So your body may downregulate, and so that it can't be stimulated by, if it's an agonist for the most part, it will downregulate the number of cell receptors. If it's a antagonist, it will upregulate and increase the number of cell receptors. You can also have cross tolerance. So if you've been taking one medication for the longest time, like a beta blocker, it won't work anymore. If they put you on another beta blocker, it's also not likely to work, for example. And then you can have tachyphylaxis, which is when you have repeated doses of a medication within a short period of time, the body will be like, nope, this isn't going to work, and the medication won't work for them at all. I don't have a good example for that, for tachyphylaxis. I say probably like antibiotics seems to hang out there. We talk about abuse and dependence a lot, right? Most of the time we're talking about this in regards to like alcohol or other patients that we see who are, alcohol dependent or narcotics addicted or stuff like that. So the most commonly abused and dependent medication is caffeine. So stimulants and depressants are both prone to misuse and abuse, right? For example, Michael Jackson, right? He could not sleep without propofol, which is like quite a flex. So they were abusing it in order to help him sleep. When you get to habituation, the body starts to develop a certain level of tolerance, right? So if you drink 1 cup of coffee a day, if you don't get that 1 cup of coffee, you're not going to be happy, right? Because now you've moved into now dependence, right? You need a cup of coffee a day to function. Habituation is like it becomes a habit. You wake up and you do something every single day. Maybe you take a Tylenol, you take a cup of coffee. It becomes ingrained in your system, where it starts to lead towards dependence, where you have like an actual physical need for it, right? You have a bad headache if you don't have your cup of coffee. You have, alcoholics who start getting delirium tremens, right? They start getting the shakes and they start sweating if they don't have enough alcohol, and that could be after missing 1 drink. So it can be very bad for a person's health, especially depending on which substance it is that they are addicted to. Oh, it's cold. Last sip of cold coffee. So, principles of pharmacokinetics, right? How the body moves and potentially alters the medication before removing it from the body. We talked about this already a little bit before, right? When we first introduced this concept. So, how is a drug absorbed? Is it absorbed through the skin? Is it absorbed through the digestive tract? Is it directly drops in an eye, nasal spray? Are there any ways that the body is going to now metabolize it so that it is effective or ineffective? So you have your first pass metabolism through the liver of whatever medication you might have taken orally, and then it starts to work. How is it being distributed, right? So most of the time, it's being distributed through your bloodstream. But beyond that, okay, is the body storing any of it? So for example, amiodarone has a very long half-life and is fat soluble. So it will remain in the body for 180 days, and it will just be in the fat cells. So even if a patient stops taking amiodarone, it's going to take a very long time for it to be eliminated because it's now bound to fat cells. I don't care how skinny you are, you have some fat cells. So what is the body doing to the drug, right, in order to move it? Kinetics is movement. So how are we moving it throughout the body? These actions that the body takes on the drug affect the onset, peak, and the duration of effect of each individual drug. And each individual drug has a different set of information here, right? So you have most oral medications take 20 to 30 minutes to start working, your onset, right? Whereas IV medications might have, a few seconds. Their peak effect, right? So if you've taken an oral medication and you have to metabolize the whole thing before it has the best effect, that might take an hour, right? It might start working at 20 minutes, but in order for it to hit the best optimal working, it might need to take an hour. And then how long is it until the body eliminates it? Okay, is it going to be that, hey, this medication is in my system for 2 hours and then it's gone? Or is it, hey, it's in my system for 180 days? A lot of your paralytics and stuff will have a varying amount of duration effect. Yes, some of these things do have are influenced by metabolism. Some of them are not. It depends on the kind of drug. Like nitro, for example, it is very fast acting, right? It's like a 5-minute duration of effect. Even if you're not metabolizing, it's being absorbed right through the mucosal membrane in the mouth. That's going to be more, rather than metabolism, that's going to be more influenced by distribution, right? If you have a decent blood pressure, in order to get it to where it needs to be. A lot of the time, distribution can affect a lot of this as well, okay? Questions, thoughts, concerns before I move on? I think we talked about most of this stuff already. All right, so bioavailability, the amount of unchanged medications that reach systemic circulation. Okay, so IV medications are like 100% bioavailable, right? Because they are not, they're going directly into systemic circulation. There's no like alteration. They get right to the tissues that they need to work on without fail. Okay, they don't have to pass through the liver. They can just go where they need to be, as opposed to GI medications, which almost always experience first pass metabolism before they start working. One medication that has a little bit of a higher bioavailability in terms of being an oral medication is aspirin. Acids like acids, bases like bases. Aspirin is salicylic acid. The stomach is acid. So it means it absorbs really, really well, which means that it can pass through the stomach membranes because it's also a very small molecule and get into the circulation really fast, really easy, and it might bypass some of the first pass metabolism, which is why aspirin is so widely used in MI. This is some BLS stuff here, right, guys? Oral medications. The patient needs to be awake and able to swallow. Please don't do that thing where we put like oral medications in a patient's mouth and they're not responsive. Don't do it. It's not a good look. Most patients take oral medications in order to treat chronic medical problems, right? High blood pressure, diabetes type 2, right? They have those oral hypoglycemic agents. You might have hypothyroidism, right? There's all sorts of stuff that we take, that patients take oral medications for. Almost all of them are subject to first pass metabolism through the liver. Things that will influence oral medication effectiveness. 1, GI motility. If you have a patient who's severely constipated, that medication is going to take a longer time to be absorbed. If you have a patient who has severe diarrhea, that medication might not be in the GI system long enough to be absorbed, right? What's in their stomach? Okay, is it really full? Is it really empty? Have they had GI surgery? Okay, oral medications might not be as readily available to be absorbed if they are, they've had a gastric bypass. The GI pH, right? If it's really, really acidic and you're taking a basic medication, a medication that's base, it's not going to be absorbed well. So just things to take into mind. Endotracheal medications are generally out of most protocols. I think that they still have them. I have to double check. They still have it in neonatal resuscitation. But there are medications that can go down the endotracheal tube. They're the lean, lidocaine, epinephrine, atropine, and Narcan. However, very unreliable, okay? You have to dilute the medication in order to get it down into the endotracheal tube. You lose a lot of the medication to the endotracheal tube itself. You have to do a sterile water flush. It's not reliable. It does not have a consistent distribution. It doesn't have the other word I'm looking for. It doesn't have a consistent absorption rate because, hey, maybe there's not great perfusion. Hey, maybe all of that medication is just sitting in the endotracheal tube. For the most part, bronchodilators and mucolytic medications are kind of what we try to hold on to there in terms of what's being put down an endotracheal tube, but we don't see this often anymore. Intranasal, more popular these days. Again, usually very high bioavailability because those mucosal membranes are very, very vascular. It's absorbed right away. It doesn't go through first pass metabolism. However, I have seen people have a lot of issues with IN medications. So 1, you need to make sure that you're hitting kind of that sweet spot in terms of atomizing. Okay, if you go too fast, you are just spraying, it's not being misted. If you go too slow, it's dripping out of the patient's nose. There is a sweet spot for IN medications. 2, if that patient's got any sort of boogers up in their nose, it's not going to be as effective. Yep, deviated septum can affect how well it's absorbed, right, depending on the access to those mucosal membranes. A couple of pro tips in terms of IN medications. If you give IN Narcan, because that's one of the most popular medications that we give, you might have to give it and then use a BVM to ventilate the patient to push that Narcan into a more vascular region in the nasal passages. I've seen it work really well. I've also seen people do an IN medication, a Narcan administration, and then use a little bit of sterile saline from like a flush, and then help moisturize the nasal passages, because if it's really dry in somebody's nose, that's not going to be absorbed well. So that also sometimes helps. Personally, I don't really care for intranasal medications. It's just hard in my opinion. Like, we can use it for Narcan, you can use it for midazolam for seizures and for EDPs. Yeah, it's great because you don't have a needle out, but at the same time, like, it's also sometimes hard to control somebody's head and long enough to get, intranasal medications up in there. IV, primarily how we administer, I want to say 98% of our medications. Okay, 100% bioavailability, starts working really fast. There are risks, inherent risks kind of associated with it. One, the biggest problem is an infiltration risk. If your line isn't good, that medication is going to go into the surrounding tissue. And depending on what kind of medication it is, it can cause some serious damage. Okay, epinephrine, right? It will constrict all those the tissues in the area and cause necrosis. D50 is highly acidic; it will cause necrosis. Which is why that D50 is sort of falling out of favor, and they're moving towards D5W drips in a lot of places. D5W is also a lot kinder to your diabetics, keeps their sugar from going like this. Some patients, you're going to have some issues trying to get an IV on. Definitely your drug abuse patients, patients who use IV drugs, right? Their veins are going to be really, really scarred, which means they're going to be really hard to get access in. Those patients also might be the patients who are going to tell you exactly which vein to use because it's their favorite, or it's one that they haven't used yet, but they've been eyeballing. Sometimes IV drug users are just as bad as medics when it comes to being like, oh, look at that vein. Patients who are in profound shock, right? Because most of the time we do not start central lines in the field and as a medic. We do peripheral lines. So if you have a patient who's in profound shock and all their peripheral vasculature has more or less collapsed because now they're shunting to their core, you're going to have a potentially hard time finding a vein that's going to work for you. EJs, relatively central, but also sometimes challenging to get to. We'll talk about that when we get to that section. Diabetics notoriously have crappy veins, usually very thin. Renal failure patients, again, usually crappy veins because usually they're diabetic and renal failure is kind of tied together. Things that I'm going to say in terms of pro tips: you might have a patient who's in profound shock and you want that large bore IV, you want something big to give them a lot of fluid, and all you can get to 22, and that's okay. Give them some fluid, bump them up a little bit, or really bad dehydrated patients, give them a little bit of fluid through that 22, and then try again. See if you have something else after you've kind of bolstered up their vascular system a little bit. Intraosseous is almost identical to the IV in terms of bioavailability and speed. The one problem that you might have with an intraosseous administration is that it's now being pushed through a bone, so it might require a little extra pressure to get it through, because it's not just, a vein is more or less empty space. A bone's got a lot more substance to it. IO is usually preferred in critical patients when you can't get an IV. So those diabetics or those patients in profound shock that you can't get an IV on, you might want to move to an IO. You are allowed to do IO in critical patients, standing orders. You are allowed to then use lidocaine to reduce pain. The patient will not experience a lot of pain when you're inserting the IO. It's when you start infusing into the bone, okay? And it's more that the bone doesn't really have its own nerves in that area. It's that the pressure of that it can be very painful for a patient. The contraindications for starting an IO, number one is fractured bones, right? If you have a patient who's got a bone fracture, you don't want to then put a hole in it as well. You might need to use a different site. So if the patient has a left tib fib fracture and they absolutely positively need an IO, you're going to go into the right leg. Bone disease, right? So patients who have really bad osteoarthritis, you don't want to now cause some sort of issue by putting in an IO. Any infection over the insertion site will then bring the infection down into the bone, and bone infections are very hard to treat. Osteomyelitis is very hard to treat. So that might be, again, you're choosing a different site. In the city, the only real approved site is the tibia. There are some places that allow the humerus, but you need to make sure that you have the correct needle, because you have a little more tissue you need to go through in order to get to the humeral site, so you need a larger needle. I'm also going to throw in here, if you're doing a tib fib or a tibia IO, any sort of knee surgery, knee replacement surgery is a contraindication in that site, okay? Because you'll just potentially be hitting metal. Not a good look. Any questions?
Nicole, is there a concern of necrosis when you do IO?
There's always a certain level of concern for necrosis and or infection. We do a aseptic technique, right? So you want to do as clean as, or a clean technique. It's not septic or sterile technique. It's like as aseptic as possible. You want to make sure you're cleaning the site. But for the most part, you can, as long as you're infusing the appropriate medications through, you should be okay in terms of necrosis. You also want to make sure that that needle is seated properly in the bone and not in the surrounding tissue. That's probably your bigger concern, is that if you put in an IO to give D50, for example, and it's not in the bone and it's popped out, it's like in the surrounding tissue, that's when you're going to see necrosis more oft times than not. All right, other medications that we usually give intramuscular. This is for any medication that you just absolutely positively need to give. So this is for your patients who are seizing, right? And you need to give them midazolam to stop a seizure. This is also, IM is usually used for, like, vaccines and stuff, since that seems to be super popular these days. Very high bioavailability as well, but it's also super dependent on how well the body is perfusing that muscle, right? Muscles have a very high blood supply, but if your patient's in some sort of shock state, they might not be able to get the medication to the rest of the body. Number one medication that we definitely give IM is your 0.3 milligrams of 1 to 1,000 epinephrine for anaphylaxis. Very rapid onset again, right? I think, if you've ever seen someone give epi, you see the patient starts to feel better almost right away. But again, you want to make sure that that medication is appropriate for an IM administration. The box will tell you whether or not it is. The labeling will tell you whether or not it is. So if you have any doubt, the medications that we normally can give IM, epi, glucagon, Benadryl, and Solumedrol, and or dexamethasone, depending on what your agency carries in terms of steroids. I think that's it. I know one of my former medic students brought up that there was some concern regarding administering Solumedrol IM because they say, oh, it might cause necrosis. Solumedrol can cause nerve necrosis, but if you are administering it in the correct location in the approved IM spot, your intramuscular injection site, usually the deltoid, right? There's like a little triangle of the deltoid that you want to give it to. You don't have to worry about a nerve necrosis, okay? Subcutaneous, again, super dependent upon whether or not there is blood supply to that tissue. Most of the time, we do not. Yep, Toradol can be given IM. Again, Toradol is dependent on agency and region because the city doesn't carry Toradol. Your benzos are also, or midazolam and Ativan. Valium is not IM approved. Subcutaneous, most of the time these are patients, the two most popular things that you'll see patients giving themselves subcutaneously, insulin, IVF medications. We do not have any medications that we give subcutaneously at this time. It's IM or IV or oral or inhaled. We don't do subcutaneous. You might see on a test epinephrine 0.1 milligram per kilogram sub-Q. Some regions do epi sub-Q. Personally, I think that if you're giving a patient epinephrine for an anaphylactic reaction, I'd want to put that right in a muscle to make sure it works properly. There's also different amounts of medication that you can give IM versus sub-Q. IM, most muscles, if you're inserting a medication, can only hold a certain number of milliliters. I believe intramuscular is up to 3. Sub-Q is up to like 1. So you're going to give a very small amount of fluid, and when you inject that fluid into the muscle or subcutaneous tissue, it creates what's called a reservoir. And the reservoir is then what the blood supply starts to pull from in order to distribute the medication. Check your textbook for the exact amounts because I do see those come up on tests. How much each muscle, and each muscle is different. So a deltoid can hold less fluid than your lateral thigh. Okay, so just double check on those, how much fluid. Most medications that we give on the ambulance, IM or IM really, does not exceed 3 milliliters. So it's not, everything comes in a very highly concentrated dose. So you don't have to worry, hopefully, about that too much, but it's something that you do need to know. Dermal and transdermal, right? Those medications, I think the most common one that you're probably going to, two common ones you're going to see are nicotine patches and fentanyl patches. Usually it's a very slow, constant dose of medication. Unfortunately, things like patient temperature and how much fat tissue is on a patient and how thick their skin is will affect the absorption rate. I've seen this a bunch of times where you have grandma who's like 95 years old and doesn't have an ounce of subcutaneous fat on her, is given a 100 microgram patch of fentanyl for the hip that she just broke, and grandma's going into respiratory arrest because that patch has been absorbed way too quickly. Okay, so if you have a curious narcotics overdose of the elderly, check them for fentanyl patches because sometimes that slow, constant dosing doesn't actually happen. It just happens way too quickly. Other ways that we can administer medications. I just saw nitro patches. Oh yeah, nitro patches. We don't do that here. There's some agencies that still do nitro paste and they'll put it on a patch. You might see that if you pick up a patient from like a cardiologist office. I don't know if nitro patches are very widely used anymore, or if they just give them the tablets and say, hey, go for it. You might see it intrafacility. Sublingual medications. Okay, so you nitro, right, is number one that we see, that we use. Might be a low bioavailability, which is why we have those repeat doses of nitro, but it's usually a very rapid absorption and a very rapid onset. Okay, this is why we give patients with chest pain nitro, because it's a pain med. In the grand scheme of things, in cardiac patients who you're giving nitro to, that is the most effective pain medication that you're going to give. Fentanyl, morphine, sure, you can effectively give it to help their pain, but what's going to help their pain the most is going to be nitro. Again, just like with IN, if those nasal membranes are very dry, it's not going to absorb well. If the patient's mouth is very dry, it's not going to absorb well. Sometimes you might have yeah, you can mask a pain. You want a patient to be comfortable, because the pain and anxiety is going to increase the strain on their heart. So you want them to be comfy. You don't want a patient to go into the hospital with 10 out of 10 chest pain and you did nothing. That's just really terrible pain. You want them, because you can tell a doctor, hey, I gave this patient, 3 nitros and 50 mics of fentanyl for their chest pain, and they're now at a 3 out of 10, and like they were at a 10 out of 10, we got it down to 3 out of 10. You're going to reduce the oxygen demand of the heart for those patients, because now you do want to keep that pain managed. Moisturize your patient. You might have to, if you're trying to give them nitro and they're very dry, you might have to get a couple drops of water in there to help move that along. Other medications that we give that are very effective is inhaled and or nebulized. Very rapid, right? Mostly we do albuterol. We also do Atrovent, as here in the paramedic world. Racemic epi, you might see some agencies. I do know that you are able to use epinephrine 1 to 10,000 as a racemic epi. If you don't have racemic, it might need to be diluted with some saline. This is also going to be a discretionary order. Albuterol and Atrovent are most commonly used inhaled and nebulized medications. So basically what you're doing by nebulizing it, you're taking this liquid medication and you're mistifying it, right? You're making it a mist. You're allowing that patient to take a big deep breath, and as you have to coach them, take a big deep breath, because when they take that deep breath, they're getting that medication directly to the alveoli, or the bronchioles, which are the target tissues. Okay, so there's no bioavailability. This is sort of like, I have an itchy rash, let me put Benadryl right on it. It's the same kind of thing. You're putting that medication directly on where it needs to work. So that's why it's so effective. Some of the medication is lost during exhalation. Some of the times you also have, those like corrugated tubes that are at the end of a nebulizer. That's to reduce medication escape into the environment. I know it looks ridiculous. I know a lot of people usually don't add that to the nebulizer, but that's helping keep that medication from just like wandering off into the environment. As nice as it is to nebulize the entire back of the ambulance, that patient needs it more than you do. Sometimes you really do need to coach patients to take a deep enough breath so that they get the medication deep enough. And sometimes it's going to take a little while for them to be able to take a deep breath, but they need to hold it in there as well so you don't lose as much during exhalation. We don't really do rectal meds. I think they actually even took it out of protocol. We were able to do rectal medication for Valium for children having seizures. I don't believe that's in protocol anymore. There is rectal aspirin. Again, not something that we do. That's a doctor thing. Again, very good bioavailability. It's absorbed relatively quickly. Because it's not in the stomach, there is no first pass metabolism. It goes right to the bloodstream because it's farther away from the liver. But the problem is it's an unpredictable absorption rate. You will most commonly see rectal medications in young children who have a history of seizures, whose parents or guardian has given them Diastat to control seizures. Okay, so Diastat is rectal Valium. It's prescribed to kids with known seizures, most of the time the smaller ones, because it's just easier to get to their butt. Most of the time, these parents will give them the Diastat and then wait before they call 911. So if you're coming and they say, hey, I gave the Diastat, didn't control the seizures, this patient's probably been seizing for a while, okay? Keep that in mind. Ophthalmic, we have one medication that we do, this tetracaine. It is an anesthetic, okay, so only for patients who have some sort of significant eye pain. Rapidly absorbed, rapidly causes anesthesia, so that the patient isn't in pain. If you use too much, it can cause systemic toxic issues. You're literally using 1 or 2 drops. I don't think I've ever seen tetracaine actually used in the field. Just FYI. If you have to irrigate somebody's eye because of, one reason or another, you can use a few drops of tetracaine. But again, limited to only anesthesia properties for that medication in the 911. Questions, thoughts, concerns? All right. Medication. Medication needs to be distributed. We've talked about this already, right? It needs to get to the tissue it's supposed to work on in order to be effective. So if you have a patient with chest pain or a rapid heart rate and that medication never gets to the heart, it's not going to be effective, okay? There are certain places in the body where there are barriers that prevent blood or prevent foreign substances, including some medications, from crossing into the cells. The three main areas are the brain, the placenta, and the testes. Okay. Number one, brain. Okay, it's called the blood-brain barrier. There are cells that surround the brain that keep it safe. That's great. We want to keep the brain safe. Really okay with that, right? So rather than having very loose intracellular spaces, you see right here, right, where stuff can just kind of go in and out, there are very tight junctions, which prevents a lot of medications from going through. One of the main issues, for example, I'm going to give Parkinson's. Parkinson's is one disease process that they're trying to treat. It's a lack of dopamine within the brain. The problem is now, how do you get that dopamine into the brain? Okay, because the blood-brain barrier is doing a really good job of protecting the brain from any medication that might affect it. So, for example, carbidopa-levodopa is the medication that they primarily use to help improve Parkinson's patient symptoms. As the initial medication, that can cross the blood-brain barrier. Once it's in the brain, it's metabolized and turned into dopamine. Okay, because if giving a patient just dopamine it was not able to cross the blood-brain barrier. The same thing with the placenta, right? The body tries to do a really good job of protecting a developing fetus. Same thing with the testicles. We want to make sure that our genetic material that we're passing on to the next generation doesn't get all wonky. So you have these barriers in place in these specific areas. In your plasma, in your blood, you do have proteins. They float around. Albumin is the most popular, most commonly measured, most commonly discussed. Sometimes the medication, depending on which kind of medication it is, it might bind to those blood proteins. If it's a bound drug, that means that you need a greater dose in order to have the best effect. Okay. If that drug becomes bound to the proteins, that also means that drug might have a longer effect, okay? Because as the unbound, you still have that gradient, right? So as the unbound drug starts to be used, it will be pulled off of the proteins to be used, okay? So it kind of has to fill the quota of how the body wants to bind it to the plasma proteins before it will start working. A lot of different things can affect this: age, nutritional status, various medical conditions, other medications the patient might be on. Something to keep in mind regarding why we use the medication dosages that we do. We spoke about this already, right? Some medications are stored in fatty tissues. They are lipophilic. They love fat. Lipofat, philic, love. And this can cause a prolonged effect, right? Because now you have a storage of this in the fat tissue. And this, again, is partially weight-based. So patients who are on larger amounts of medication, because they are larger individuals with more fat stores, may have a longer medication effect than thinner patients or patients with nutritional deficiencies. Volume of distribution, right? How how the medication will spread within the body. If you have a low distribution level, right, these are medications that are not going to get distributed to fat, tissues, etc., or other tissues. It will have a very high plasma content as opposed to high volume of distribution, where you lose a lot of the plasma concentration and therefore distribution to the bones, teeth, fat, etc., etc. Okay. Not something I'm super concerned about you guys knowing. I'm more concerned about you guys understanding the concept of biotransformation, though. These are important, okay? Biotransformation, this is usually what happens during first pass metabolism, right? The medication goes through the liver and is transformed by the body. So the liver starts breaking it down. Most of the time, what it does is it breaks it down into metabolites. They may be active or inactive metabolites. The active metabolites are what are usually give you the action of the drug that needs to undergo first pass metabolism. These are the things that go and do what they need to do. The inactive metabolites are generally just then eliminated from the body, and they don't really contribute. Another view of what biotransformation does. Okay, so it might be an inactive substance that becomes active. It might be an active medication that becomes completely or partially inactivated. One active medication can be transformed into a different active medication, or the medication is transformed into something that's easier to eliminate. So medication errors. Medication errors are probably the biggest issue that we have in EMS. We are working under stress. We are working in usually a lot of this time, right? There's a limited amount of time that we feel that we need to get these patients medications. And a lot of errors are made. We also don't necessarily ensure that we are protecting ourselves and we're checking the medications. We don't have policies and procedures in place to make sure that we don't give the wrong medication or the wrong dose. For example, I was in my paramedic internship. We had a patient, we wanted to give them diphenhydramine. So I went to go draw up the medication. I was drawing it up. I'm like, this is a lot of medication. Like diphenhydramine is 1 milliliter. Why do I have 3 milliliters? Because I knew I had to draw up a whole vial. I look, instead of diphenhydramine, I had picked up diltiazem. Okay. So if I had given that patient, even any of that diltiazem, it would have been a problem. Okay. So this is when you want to make sure that you have your rights, right? So you have the right patient, right? Is the patient that I'm treating actually experiencing what, they need to be treated for? So if I have a patient who's asthmatic, am I giving them the right medication? Okay. Or is my patient not actually asthmatic and they're an APE? And if I give them asthmatic patient AP or the APE patient asthmatic medications, what's going to happen? Is it the right medication? Okay. There's no allergies. There's no other contraindications to the medication that we're giving. What's the dose? Okay. What dose do I need to give this patient? Most of the medications that we have are pretty standard dosing. Okay. Right. It's a one shot. You're going to give 125 milligrams of solumetrol. You're going to give 0.3 milligrams of epi. What's the route? IM, IV, oral. What are we doing, right? Is it a approved route? Is it the right time, right? I have a patient who's having an allergic reaction. I want to give them epi, but they're not in anaphylaxis, right? Is it the right time to give them that medication? Have I done a good assessment, right? Have I told the patient, have I educated the patient of what to expect, what the potential side effects are? Is there any refusal or questions about the medication? Does my partner think it's not a good idea to give the medication, right? So you have to talk to your partner. If you're working in a double medic system, that's a great resource. Even if you're working in a Mensa medic system where you have a BLS provider and they're looking at you going, no, something's not right. I don't think we should give them this. Okay, let's reassess. Like, let's go back and look at it as again. Maybe there's something we missed. Have you done a good evaluation? Okay, and then documentation. I gave this patient 324 milligrams of aspirin because of chest pain, or I wanted to give this patient nitro and they refused because they didn't want the side effects. I went to go give this patient nitro and I didn't give it to them because they had just taken erectile dysfunction medication and their blood pressure wasn't good enough to support a nitro administration. Okay, so all of these need to be in place for proper and high quality patient care. All right, we talked about this a little bit already, but different types of drugs that we have. We have the sympathetic nervous system drugs. Sympathomimetics, okay? They mimic the sympathetic system, right? And the sympathetic nervous system, right, is your fight or flight. Anything that you would imagine happening as you're having a fight or flight response, okay? These drugs mimic them. As opposed to a sympatholytic, lysis, cell breakdown. Doesn't happen, right? It breaks down the system, okay? So it would block. So here's your agonists, your antagonists, okay? Makes it happen, prevents it from happening. You have 4 different receptors in your sympathetic nervous system. Your alpha 1, your alpha 2, your beta 1, and your beta 2. You see this little thing right here. A, B, C, D, alphas constrict, betas dilate, okay? So alpha 1 receptors constrict the blood vessels in the periphery. Alpha 2 prevent the alpha 1 receptors from going too crazy, okay? It's like the checks and balances. Periphery. Alphas almost just if you think about anything alpha, this is your periphery. Levophed is an alpha sympathomimetic. Alpha 1 sympathomimetic. It constricts the blood vessels in the periphery, redirecting blood flow back to the heart. For your betas, you have 1 heart and 2 lungs. Your beta 1 receptors are primarily in your heart. Your beta 2 receptors are primarily in your lungs. Beta 2, right, in the lungs, albuterol, best example, beta 2, right? It's a sympathomimetic. It dilates the airways in the lungs because it's stimulating the beta 2 receptors. Most commonly we see in regards to beta 1 receptors, we see the beta blockers. Those are sympatholytics. They antagonize your beta 1 receptors, preventing dilation and preventing the heart rate from getting really too high because it's on top of dilation. Beta 1 also is rate control for the heart. Does that make sense? Any questions about that? That's really important. This will come up over and over again. This is like foundational stuff that you need to know. Right. We also have medications that we use in airway management. Most commonly in the city, they use etomidate as a sedative hypnotic. It's not a paralyzer. It is not an amnesiac. It just kind of chills you out and reduces your ability to like control some muscles, but it's not paralyzing you. It's not causing you to forget. Ketamine is also in the sedative hypnotic. It's a little more potent than etomidate because it's also a dissociative agent. So like think of out of body experiences. That's ketamine. Your benzos are also used in airway management because they do produce amnesia, okay? This is helping this patient be not anxious and to hopefully forget that you're sticking a tube down their throat. Agencies that have chemical paralytics, the patients will be paralyzed. We talked about this already, you can be paralyzed without being sedated. Not a great place to be, okay? This is a little bit better than just being just paralyzed. It's best to have both, okay? Let's see, hold on. A lot of times these medications will work on the nicotinic receptors in the brain, which creates like your acetylcholine. You'll either have a polarizing or non-depolarizing paralytic. We'll talk about that a little bit more when we talk about different medications, because that's a lot of information. It's dense, so we'll talk about that later, but just be aware that those are medications that are commonly used in airway management. Other airway management medications, right? We talked about this already. Your beta-2 agonists, albuterol. Another medication that always seems to pop up is terbutaline. State test question. Terbutaline is not only a medication that can be inhaled, it's also given IV. They love it. I have not seen terbutaline on an ambulance ever. I don't think I've even seen terbutaline used in a hospital. But hey, let's talk about it. Most of the time, your beta-2 agonists are paired with other medications. So Advair, right? Or in the disc medications, right? They come in this little disc. It's a pill that they crush and they inhale, right? So leukotriene blockers, corticosteroids, these are all medications that kind of help overall reduce airway inflammation and that influx of mucus that's associated with asthma. Albuterol can be effective on its own, but you have to remember that asthma is a two-prong disease. So you have your airway constriction and your mucus influx. On the ambulance, we can give corticosteroids to help reduce that mucus influx. Any questions? Oh, thanks, Alyssa. I was about to say that. You need to go fill out a COVID form and if you're going to NYU, check your email. There's a hospital COVID form. Send it back to Scott today before lunchtime. All right. Antidysrhythmics. Your five classes of antidysrhythmics. Your class 1, sodium channel blockers. Okay. These are agonists in the sodium channel. They are commonly used for ventricular dysrhythmias. Okay, we'll talk about that more in cardiology. It's all going to start tying together, but just you need to know the classes right now. So your first class is your sodium channel blockers. You have 1A, which is procainamide, and 1B, which is lidocaine. Again, we'll talk about that more in the future because let's just get the initial information in now, and then we'll start adding pieces of the puzzle. Your class 2 are your beta blockers. Commonly used ones at UEC are metoprolol, carvedilol. Some agencies carry labetalol for hypertensive crises. So beta blockers are your class 2. Class 3 are your potassium channel blockers. Most commonly used is amiodarone. The fun thing about amiodarone is it also has calcium channel and sodium channel blocking properties as well. It is not a pure potassium channel blocker. I call it the duct tape of cardiac medications. It's kind of used for a lot of different things. It's very effective, can be very toxic in patients with like liver or kidney issues. But very potent medication. That's your class 3 potassium channel blockers. Your class 4 are your calcium channel blockers, diltiazem or your cardizem, right? That's the same medication. We carry that on the ambulance. Very commonly used for rapid AFib, okay? Calcium channel blockers are very effective. Verapamil is another one that you might see patients taking at home. So your class 4 are your calcium channel blockers. So that means you have S, B, P, C. As my husband likes to say, Stony Brook paramedic class. To remember the order. And then you have class 5, which is adenosine, which kind of does a whole bunch of stuff. And they're like, yeah, no, it does things. And you're like, what do you mean it does things? And it's like, well, it stops your heart. You're like, oh, okay, that's exciting. That's fun. So it's not really classified in any of those antidysrhythmics. We use adenosine for your pure SVTs. And again, we'll talk about that more later. Just remember, adenosine gets to have its own class. Some medications that you might want to be a bit familiar with, just in general, not necessarily that we're carrying it on the truck, but that you might see patients taking. Clonidine, not to be confused with Klonopin. Okay, clonidine is an antihypertensive. Klonopin is an antipsychotic. Again, similar sounding medications doing totally different things. Clonidine is an alpha-2 receptor agonist. Okay, it helps reduce alpha-1. So alpha-2 is that brakes on alpha-1. So alpha-1 is constricting the periphery. Alpha-2 makes sure that that alpha-1 doesn't constrict it so much that you have a high level of afterload, which increases your blood pressure. Okay, right? So if you're pumping, if your heart's pumping against a very tight system, it's going to increase the blood pressure. Clonidine helps reduce that. Clonidine is given in very small doses. The most common dose that you see patients starting on clonidine is 0.1 milligrams. So if you have a patient who's on like 0.3 of clonidine, that's a massive dose of clonidine. Just heads up. Very potent medication. It can drop, patients who have just started clonidine might see significant drops in their blood pressure. So you might get a call for patients who are really dizzy or passed out or something because they've just started clonidine. Just things to know. The reason that we have labetalol in antihypertensive crises is because it's very potent and it's like a broad spectrum beta blocker. Okay, so this is preventing the heart rate from going up too high. It's preventing too much alpha-1 restriction, so it's going to dump the blood pressure. Okay, this is very commonly used in patients who are like very, very high blood pressures, like 300 over 150. Okay, again, this is dosed out appropriately. We in the city do not carry labetalol. You might see it in other places. So we talked about ACE inhibitors, right, and how they sometimes cause angioedema. But for the most part, ACE inhibitors work on the angiotensin cascade. Okay, so this is kind of what your kidneys do when it starts to think that it's not getting enough blood. So your liver always puts angiotensinogen, mouthful, in your blood. Okay. When your kidneys feel like they're not getting enough blood, what they do is they release renin. Renin converts angiotensinogen into angiotensin 1. Other enzymes floating around in your body, such as ACE and trimase, will then convert angiotensin 1 into angiotensin 2. This is where it starts to go down. It'll break down and turns into aldosterone, and aldosterone receptors start to constrict your periphery because now your kidneys are saying, I'm in need of blood. Send it to me. Okay. So if you have a patient who, is hypertensive, it starts to break down this system. Okay. Because if your kidneys aren't getting enough blood flow or feel like they're not getting enough blood flow, they set this into motion. The ACE inhibitors work here, preventing angiotensin 1 from turning into angiotensin 2. Okay, just something to know. There's also angiotensin 2 receptor blockers, ARBs. These are sort of coming, I feel like losartan, a lot of these were being taken off the market because they were causing cancer. There are still some ARBs floating around, and instead of working over here, it just works here and it blocks this transition from angiotensin 2 into aldosterone. Okay, same thing, just a little bit later in the process. Other antihypertensives that exist are vasodilators, isosorbide. Isosorbide is a long-term oral nitroglycerin. It's pretty much all you really need to know about that. It just dilates the blood vessels so that constriction that the heart has to pump against is a lot lower. Again, this is a medication that if you have someone starting, it's like a new medication for them, you might see them kind of tank out. It's supposed to be extended release, as opposed to nitro, right? So nitros are, pretty much spot treatments, and isosorbide is supposed to last a little bit longer. Questions, thoughts, concerns? All right. Other medications that you might see, we have drugs that affect the blood. So you have your anticoagulants. Most commonly, we see warfarin. Okay. Anticoagulants are used for patients who have clotting issues or blood stagnation issues. So AFib, DVTs, any sort of mechanical heart valves, right? These are the patients who you're going to see who are on warfarin. As opposed to antiplatelet medications, which are patients who have sudden clotting issues, right? So your MI or stroke patients. So patients who might have had any sort of MI or stroke and then a follow-up stent to that, or some sort of peripheral artery disease where they have, it's less of a stagnation issue and more of a sudden clotting issue, they'll be on an antiplatelet therapy. We talked about Plavix already, right? So Plavix might have that, some patients who are on Plavix don't know that their Plavix isn't working, so they still might have issues. Other things that we have, not us in particular, but TPA, which is a clot buster. It breaks down the fibrin in clots. So if you have a patient who's having a stroke, this is usually what they give. TPA is carried in some agencies, not here. And can cause significant bleeding. There is a long checklist of contraindications for patients who can receive TPA. Most of the time, TPA is given to patients with ischemic stroke. Some areas will also give it to patients who are having an MI rather than doing stents. Sometimes they'll do spot therapy. So if you have a patient who's got like a bad pulmonary embolism, they'll go up and they'll insert TPA directly into the clot, so it's not as systemic. Kind of cool. But something to know, not something that we operate with here in this area. Diuretics. Diuretics are often used for patients who have congestive heart failure. It also can be used as an antihypertensive, depending, usually it's in a dual treatment kind of thing. So a lot of times you'll see patients on thiazides, hydrochlorothiazide, in fact. Hydralazine is another popular one. Hydralazine is also has vasodilation properties, so it increases the blood flow to the kidneys. Basically what it does is it helps try to reduce volume issues. So if you're not pumping as much pure fluid around, your heart doesn't have to work as hard. That extra fluid doesn't end up in the lungs and creating pulmonary edema. Lasix and Bumex are also super popular. We still carry Lasix. It's falling out of favor in the 911 system because it takes like about an hour or so to work. So we don't see any real immediate effects of Lasix. But these are definitely medications that you need to kind of just be familiar with, that they are diuretics, which would give you a clue as to what your patient's medical history might involve. All right, so we talked about opioids already a little bit. So opioids sit on the mu receptor of a cell, and when they sit on the mu receptor, they start to kind of just knock all of your respiratory drive and stuff down. So just things to keep in mind. We talked about that. That's it. You know, I think we're all relatively familiar with opioids at this point. That delightful opioid crisis has been going on for quite a while. So basically when it shuts this down, it shuts down the calcium gates, and when the calcium can't get in, you have fewer neurotransmitters and you have decreased mental status. All right, things that we have that you have the opportunity to carry and is very effective, especially in anaphylaxis, is Benadryl. Benadryl is a histamine 1 blocker. Okay, histamine 1 blockers are all over your body. Histamine 2 blockers are primarily in your stomach and digestive tract. Okay, when you have a patient who's having an anaphylactic reaction or an allergic reaction, the hospital, the only thing that we can't give is Zantac, and the hospital will usually give that. And they're like, here you go. They're like, that's it. That's all they. If you come in having treated a patient for anaphylaxis and you've given them the whole protocol, the hospital's like, well, cool, we can't do anything. Here's some Zantac. So basically, what happens is as the histamine is released, it starts to in an anaphylactic reaction, it increases calcium, which increases muscle contraction, making it harder to breathe. It also increases the permeability of the capillaries, which is why the patient starts to go into shock. And that's why they also end up with the swelling, because the capillaries start to leak. Okay. In the blood system, you have increased capillary permeability. This is, you get patients who are vomiting and stuff like that. We don't deal with H3. But yeah, so histamine 1. So Benadryl comes in and prevents muscle contraction, prevents that, it helps reduce the increased capillary permeability and starts to put everything back in order. Glucagon. We use glucagon when we can't get a diabetic patient to have a better sugar, right? Your hypoglycemic patients, you can't get an IV, you don't want to do an IO, they can't swallow, and you don't have any vasculature on them yet. The glucagon converts glycogen in the liver into glucose. It takes quite a while to work, unfortunately. I have never seen a significant change in blood sugar after a glucagon administration. Maybe a few points here and there. Sometimes those like 1 or 2 points is just enough to get that patient awake, but it kind of buys you a little bit of time while you're trying to see if you can get an IV for them or you can get them to eat. Glucagon is also used in beta blocker overdoses because it will help increase the heart rate without using the beta receptors. It kind of works around the beta receptors through other channels that I'm not going to bore you with. Just know that that can also be a discretionary order in a beta blocker overdose. They will have you give the patient IV glucagon if you call for it. Ooh, that's it. Thoughts, questions, concerns?
Is liver function needed for the glucagon and the beta blocker overdose?
In the beta blocker overdose, no. In order to increase the blood sugar, yes. The problem is if you have a bad or fragile diabetic, they might not have good glucagon or glycogen stores. So even though if you give them glucagon, it might not actually improve their blood sugar if they don't have the stores to do it. It can also potentially take some of the glycogen from muscles, but again, if you have a really fragile diabetic, they might not have those stores to begin with. In regards to the beta blocker overdose, no, it works in a different function for the heart rate. Other questions?
I think Mike's dead.
Yeah, I think so too. All right, I'm going to give you guys a 5-minute break. Be back by 11. Someone try to wake up Mike, please. Recording. Oh, son of a monkey. Hold on. I done messed up. All right, a lot of this is probably relatively familiar because we did a lot of this already in the last lecture. Medication administration, the fun part of being a medic. Sometimes your patient's survival will 100% depend on your ability to, one, identify what's going on with them and then choose the appropriate medication. So I like to use the anaphylaxis example. You have a patient who's in anaphylaxis and they can't breathe, you need to give them epi, but you can't flip-flop between, oh, maybe it's anaphylaxis, maybe it's not. You need to be decisive. There's going to come a time when you're going to have patients who are in that weird gray zone, and you're going to have to just be like, I'm sticking to my guns and I'm doing this, because you're not going to necessarily have a great differential diagnosis. Maybe you don't have good information from the patient for history, what happened leading up to that event, but you're going to have to make an executive decision. This is the point in time when having confidence in your ability and your ability to handle things, even if it goes a little sideways, is going to be important. And it's going to take a little time to develop that because there's a little queasy feeling where you're like, somebody's life is in my hands. If you don't have that queasy feeling, you probably aren't trying hard enough. And that's even scarier. So we talked about the rights already. Here's the 6 rights. I know we extended it to 10 rights in the last lecture, but these are the most common that you need to know that we use. I think having a better understanding of the 10 rights is probably going to make it better in the grand scheme, and I'm sure they're going to start moving to that. But the right patient, the right drug, the right dose, the right route, the right time, and the right documentation, right? You need to know those. Those are going to be part of your whatchamacallit? Your testing, your skills testing. It's gonna pop up when you start doing medications. This is a critical, okay? Know the 6 rights. So you always have the option of discussing your concerns with medical direction. If you are treating a patient and you're like, you know what, something doesn't feel right, I really don't think I should do this. I had a patient once, and this wasn't a medication in particular, but we got there and he was unresponsive, a heart rate of 180. Blood pressure was like 70. He had just finished running 4 miles. Unfortunately, it was a 5-mile race and he didn't make it to the end. I felt really bad for him. Full pale diaphoretic, completely unresponsive to pain. Went cardioverted him because he was an SVT of 180. He's unstable. Hit the cardioversion. His heart ticked right through it like we did nothing. And I was like, this isn't SVT. This is something else. So got 2 large bore IVs, start some fluid running, and I call medical direction. I was like, hey, I don't think that this is SVT. There's something else going on. Like, I can't put my finger on it. What do you think? I got Dr. Hegge. How far are you from the hospital? I'm like, wow, 5 minutes? He's like, go to the hospital. I'm like, okay, great. He goes, but cardiovert them one more time and see what happens. I was like, okie dokie. Nothing happened. Went to the hospital. Ended up the patient was in severe rhabdomyolysis from being completely untrained and deciding to go run 5 miles. So he had large molecules of protein floating around and just from muscle breakdown, messing up his entire system. He ended up getting like 6 liters of fluid to kind of start fixing him, and he had serious kidney issues afterwards. But hey, I wasn't sure. I had a patient who I was pretty confident had a beta blocker overdose. I called and they gave me discretionary orders, okay? So if you have any doubt of what's going on and what the treatment should be, talk to somebody who has way more school debt than you do. Let them make the decision, okay? Let them take the liability on themselves. When you are calling for an order, get the order, repeat the order, and if you have any questions, ask the doctor, okay? And say, hey, are you sure? You said you want me to give this patient, 500 milligrams of epi. I think that's a lot, right? Okay. Oh, sorry, wrong drug, right? Oh, do this. I've had, medical direction be like, give this med. I'm like, doc, I don't carry that med. I don't have that med. Do you have another option? Okay. Always clarify with medical direction. Make sure you have good communication either way. Okay. Again, make sure you verify your rights, and make sure that your documentation marks down what you did, how much you did, if the patient had any response, right? Okay, I gave this patient 6 milligrams of adenosine rapid IV push for their SVT. Their heart rate was 220. After administration, the patient's heart rate was reduced to 80. Patient felt better, blood pressure improved, went to the hospital. Okay, you need to make sure that you document that. Okay, I gave the patient 6 milligrams of adenosine, heart rate, no improvement to heart rate, moved on, gave them 12 milligrams, no heart rate, no improvement to heart rate, cold medical control, got an order for cardioversion, right? So make sure that you document everything that happened and if the patient had a positive or negative response. You'll also see a lot of your electronic ePCRs. New York State just did an update with what data that they're collecting, and that's actually a critical requirement. They won't let you upload an EKG or an ACR without positive or negative effects. We kind of operate within the medical asepsis or realm, kind of. We're really just kind of cleanish in an ambulance. So sterilization is destruction of all living organisms. So it's either heat, gas, or chemicals. I do believe there's also pressure can be used in some sterilization techniques. Antiseptics is there's no living killing of living tissue. So you have alcohol, iodine, anything that you're doing prior to like a insertion or like cutting a patient in surgery, something like that. Like this, you'll have a sterile field in surgery around the patient, and the area that you're operating in is has been antisepticized. And then disinfectants are things that kill living tissues and pathogens. So like your purple wipes, you're not going to use like on your hands. Not good. That's you're using that for like hard surfaces. Disinfectants are for hard surfaces. We use clean technique because it is almost impossible to do sterile technique in an ambulance. We don't have a sterile field. It's very challenging to create a sterile field. The second that your hands drop below your waist in the sterile field, they're no longer considered sterile. So we don't have the time to do that in an ambulance. So we use clean technique. We're just trying as hard as we can to reduce contamination and reduce infection. Standard precautions for everything and anything. If there's any possibility of something icky, sticky, and gooey getting on you that is not yours, you should be using standard precautions. I don't think I really need to repeat this because COVID. Again, same thing. Hand washing, most effective way to stop the spread of disease. Again, don't think I need to really beat that to death. Sharps must go in a sharps container. They can't go in your pocket. They can't be stabbed into the bench cushion on the ambulance. They should not be floating around. They need to go into a puncture-proof sharps container. State test question. You make sure at the end of tour, you're actually, the way they're supposed to do it, no one does. You're supposed to actually count the number of sharps that are in your sharps container at the end of the day and empty the sharps container. No one does it. It's, but if you ever see that's the proper way to deal with sharps. Do not recap needles. Okay. I know we do that in some areas. Maybe you've got a discretionary order for 5 milligrams of midazolam on standby and you're pretty sure you're going to use it. So you draw it up and you put the cap back on and then, oh, patient seizing again. There we go. We do that sometimes. You should also be attempting to do all invasive procedures on scene. And by on scene, we mean while not in motion. That could be in the patient's house. That could be in the back of the ambulance. You don't want to, most of the time, you want to try not to try to start an IV or administer an IM drug while the ambulance is in motion because it just increases the risk of you stabbing yourself. If you stab yourself with a clean needle, that's one thing. You put a Band-Aid on it, you call it a day. If you stab yourself with a dirty needle, whole other bag of worms. You have to talk to your infection control officer. You should be getting, blood drawn at the hospital for baselines. Becomes a workers' comp thing. So if possible, and sometimes it's not possible. Sometimes the patient decides they're going to start seizing in the middle of the ride, or you need to give them medications. Or sometimes you have a diabetic who tanks, or you have somebody who just, you really need that next IV or something like that. But you also, they're a bad trauma patient. You shouldn't be sitting on scene. It happens. Just be very, 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 very careful. Most of your blood is the plasma, okay? Right? So most of your body, I like to say that we are all generally cucumbers with emotions, right? We are mostly water. Most of your body weight is water. Even in your blood, only about a small amount of actual formed products that consist of your blood. It's mostly just plasma. A solvent is water. A solute is what is dissolved in the water. So your blood is technically a solution. The plasma is water. The solute is a dissolved element. In your blood, you have electrolytes, right? So your ions, you have cation, which are positive, and anions, which are negative. And you have non-electrolytes such as glucose, which is a very large molecule. You also have urea, which is a waste product. There's other proteins that float around. There's a whole bunch of stuff that's like in your blood, okay? Your most common electrolytes are these 5. So you have potassium, which is the most common intracellular electrolyte. Test question. Most common intracellular electrolyte is potassium. Sodium, most common extracellular electrolyte. You have chloride, right? So your NaCl, sodium chloride, table salt, breaks down inside your blood into Na positive and Cl negative. Mag and calcium are opposites, or they kind of hang out, and also potassium. So you see positive charge, positive charge, positive charge, positive charge, negative charge, okay? Bicarbonate is another electrolyte. It's a hydrogen, a carbon, and 3 oxygens. Okay, this is what your kidneys make to buffer your acids because it breaks down into water and a carbon. You have, all right, so these are the ones you need to be most familiar with. They all do different things inside your body. I believe I can talk about that really soon. In regards to fluids and electrolytes, in most situations, the world likes to be in balance. Okay, so if you have a fluid and you have a membrane in that fluid, the world wants an equal number of electrolytes on one side of the membrane as the other side of the membrane. So if the electrolytes can't move, water will move in order to balance that gradient. Osmosis is water movement, where diffusion is the like compound or the solute movement. Okay. Filtration is what we most commonly see in both the lymphatic system and in the kidneys. High pressure fluid is pushed against a filter or a membrane, and the solvents or solutes and some of the solvent is pushed through the filter, right? Not hard. If anyone's ever seen a filter, a pool filter, etc., right? You're taking out waste products, you're taking out something that is too big, and it's being removed. And then you have your active transport, right? So your active transports, you see most commonly in the heart. There's other locations in the brain and wherever where you need to move electrolytes against the gradient. This is most of your cells, right? So you have very high concentrations of potassium inside of your cells because energy is keeping it there, okay? It's preventing that regular diffusion where there's a balance between sodium and potassium. So you have these active transport gates keeping the potassium inside the cells. In order to actually make a patient better, the best fluid to replace blood is more blood. Unfortunately, blood is a commodity. It is not super transportable. You need to keep it refrigerated appropriately. It has a shelf life. So not a lot of EMS systems will carry blood. Anyone know what the universal donor is?
O negative.
Negative.
O negative. Things that I learned. You can apparently put O positive. Men can receive O positive without any negative effects because the positive and/or negative is really mostly for women of childbearing years, which is a big issue because you could destroy the fetus. But yes, O negative is the universal donor. Okay. So if you have O blood, which has 0 antigens, and you also are negative for the Rh factor, you can give your blood to anybody. It's just kind of generic blood. White girl blood. So different IV solutions that we potentially can see. For the most part, we only operate in the crystalloid, in this region. We only operate in the crystalloid area. We have normal saline and lactated ringers as the 2 that we can see on the ambulance. For the most part, you're dissolving electrolyte crystals in water. It goes into the body, into the vasculature. it's like a buffer. It just kind of pumps it up. Lactator ringers is usually a little bit better in almost all patients other than kidney failure patients because its electrolyte solution is very similar to that of plasma. Okay, so it's got sodium, potassium, mag, a little bit of calcium. It's got a little bit of everything in it. Test question. If you administer a patient 1 liter of fluid, after 1 hour, 2/3 of that fluid will no longer be in the vasculature. Okay, it will go into the interstitial spaces, into third spacing. That doesn't stay there for long. It's a temporary fix. Okay, I've seen that one on the test a bunch of times. Okay, colloids, on the other hand, contain large molecules that can't go through membranes. So basically, once you start putting large molecules into the vasculature, the body's like, what is this shit? And then starts to try to diffuse or dilute it. And if those molecules can't get out of the vasculature, the body sends water in, right? That osmosis. So as the water goes in, you start to dehydrate all of the cells in the area. Isotonic has the same concentration of sodium as a cell. This is your lactator ringers and your normal saline. They are isotonic solutions. They're the same concentration, about the same pH. They're happy, okay? Sodium is what we're looking at in these particular areas. Hypertonic means it's got a lot more sodium than the cell. So you will see this is 3% saline, not normal saline, 3% saline. Okay, they use this very rarely, but they'll use it in order to reduce edema in cerebral edema, because again, the body's like, we need to to get rid of some of this salt, and it tries to balance it all out. When you have a lot of salt in the blood, that salt then moves into the cells. Okay. Then you also have hypotonic. This is 0.45% saline. Does not have as much sodium. It's mostly just water. So now you have cells that start to blow up with water because of osmosis. Here we go. So hypertonic causes the red blood cells to give up their water to try to dilute the plasma. Isotonic, everybody's happy. Hypotonic, there's too much. There's not enough salt inside there's too much water outside the cells, so the water flows into the cells and causes everything to burst. Okay. Not really something that you need to really worry about too much, but this is just a concept that you kind of need to understand. This is sort of like why slugs die. If you sprinkle salt on slugs, they become it's a hypertonic situation for them, and it causes their cells to go for them to dry up. It's like when you brine foods, right? Or over here, hypotonic, you're rehydrating dried fruit. Okay, you put a raisin in a glass of water, you make it hypotonic. Just a concept you should be kind of familiar with. Oh, hey, the 3-to-1 rule. This is very similar to what I just said about the 1 liter of blood. You need 3 milliliters of fluid to replace 1 milliliter of blood. Again, fluid can't transport oxygen. The problem when you have a patient who's losing blood is now they also lose their ability to transport oxygen. So just keep that in mind. After 1 hour, 2/3 of that crystalloid solution will no longer be in the vasculature. Seen that on the state test a bunch of times. In regards to medication administration, we have 2 administration sets. Your macro set, which makes macro-sized drops, and your micro set, which makes micro-sized drops. Generally, your macro set is 10, 15, or 20 drops per milliliter. This is what that means. And your micro set is always 60 drops in a milliliter. So it's like an eyedropper, right? If I give you 60 drops of micro drops, that's gonna make up 1 milliliter. If I give you 10 big macro drops, that's the same. Okay, so we use the micro drops for very precise medication administration, like when you're giving a dopamine drip, where macro drips are used more for, this patient needs fluid. So this is when you're making your decisions. There's been times when you have maybe a patient who needs fluid, but they're a CHF patient. You might want to put a micro drop set on that fluid to make sure that it doesn't run away from you, because sometimes macro drop sets can run away from you. You're like doing something else, you look up and you just put a liter of fluid in the patient and they're like, So just things you'll start to pick up as you do rotations. When you're choosing an IV site, and hopefully this will actually happen when you do your skills, you'll learn this a little bit better. But I want you to start making some friends and feeling up their arms, okay? Also, I'm all about feet IVs. When you don't have a good maybe arm, for example. It's just like doing it in a hand. It's just a little bit, different. Start filling up veins. The veins should be firm, straight, bouncy. Joints are hard, so like everyone puts things in the AC, which is your antecubital area. But the problem with the antecubital area is if you put an IV here, the patient goes like this, they're cutting off their administration. I like to go for the forearm because you can't bend a forearm, right? You can have an IV that ends up being very positional just because the patient starts moving. So if you avoid joints, you'll be okay. Dialysis fistulas, no go. Patients who have had a mastectomy, no go on that side because any pressure or any fluid can end up with a lot of edema. Patients, you may or may not have the ability to avoid like edematous extremities, right? So patients really bad CHF, maybe they have like bloated up arms. If they have no other site, that's kind of and you really need an IV, that might be where you go. Highly, highly recommend going and palpating a bunch of people. The intern vein is right here. This is a very popular, called the intern vein because doctor interns were always going here. It's very much, you have a vein like right up on the surface. The problem is it's a bit of a painful location, okay? You guys will start learning how to do IVs and you'll learn some tricks. I'll probably teach you some tricks too later on once you start getting familiar and feeling a little creative. EJs in the neck can be a little tricky. You don't always get flashback. And we talk about flashback, you know you're in. You put the needle in and you get blood return. You don't always get flash with an EJ because it's under such pressure, okay? Whenever you're starting an IV, the point of your needle should be pointing at the heart, okay? You're always putting an IV in a vein. You're never putting it in an artery. If you end up doing an EJ and you get pulsating blood, that's an artery. You're going to DC that and apply lots of pressure. But you also want to make sure that you're not putting any air into that catheter because you could cause an air embolism. EJs are a doctor and medic thing. Nurses aren't really allowed to do EJs, which is kind of funny because of the risks. But sometimes you really need a patient to have an IV, and that's all you got. You'll start to be able to kind of see those a little bit better as you're becoming a little more familiar. So just something to keep in mind, depending on who your medics are when you're doing rotations, you may have the opportunity to do this, you may not. Geriatrics. Sometimes you might have to size your needle down. Sometimes the IV will be really good, but the pressure of you pushing the flush might be a little too much because they have fragile veins. So you might want to consider using a smaller size, 20 or 22. I like to do 18s on people. It's a good size. If you have a patient who you suspect is going to need blood transfusion of any kind, you should do a 20 or better because they won't do a blood transfusion they can't do a blood transfusion through smaller veins. The elderly also have kind of like folded skin, right? So you might need to hold their skin taut because they have lost a lot of collagen over the years. You might want to size down your drip set to a micro drip instead of a macro drip, just again, because we talked about that. When you're doing an IV, you need to remember that the smaller the number, the larger the catheter size. And by catheter size, we mean the lumen, okay? So a 20 gauge is going to be smaller than a 14 gauge. Personally, I like 16s better than a 14 because most of the time the 14s that you see on the truck are very, very long. Those 14s are very long because they're also being they're serving a dual purpose as also being a chest decompression needles, catheters. Firefighters, if you have a wide lumen and a long catheter, you're going to have a slower flow than a slightly smaller lumen and a short catheter. Okay, you want to reduce, if you're really trying to pump a person full of fluid, you want to reduce the amount of friction that that fluid is experiencing in the catheter. You're going to learn all about traction and how to, the appropriate amount of traction to apply to a vein. There's a whole set of muscle memory skills that you guys are going to start learning. IVs are probably the more fun part. That IVs and intubation are probably the most fun parts of medic school. You're always going to insert the bevel side up. Okay, that's the same thing with when you're intubating. The bevel's usually up. The constricting band that you're going to apply, you're going to make sure that it's only tight enough for venous circulation, and that you're going to remove it pretty immediately after you've successfully inserted the catheter. You're going to learn how to set up an IV bag if you don't know how to do so already. You need to make sure that IV tubing is flushed fully before you hook it up to a patient. That is enough air to kill a patient. Okay, don't do it. Saline locks are kind of standard of care now. There was a point in time when IVs were being directly hooked up to the hub, the IV tubing. We don't really do that anymore. You want to make sure everything's flushed and the drip chamber is about halfway to a third. You don't want it more than that because you want to be able to see the drops falling so that you can know that the IV is running, and you can then titrate your medications. Troubleshooting stuff that you're going to start to learn also as you do IVs. The flow rate can be affected by a number of different things. Always make sure that the IV bag is above the level of the heart for the patient. Make sure that you've taken the constricting band off. Make sure that it hasn't infiltrated. The IV site, you can also, not only can it have an infiltration, if it's not flowing well, it could be, again, positional. Sometimes you'll see, like, medics will do this. They'll insert an IV and they'll pull back on the saline lock a little bit just to kind of reposition the catheter inside the vein, and it'll start running. Sometimes the catheter ends up on, like, pushed up against the edge of a vein, and it doesn't flow well. So you might have to do a little magic with some tape to pull the catheter back so you have good flow. Local reactions, always good to know. And see, this is the old school pre-tegaderm. You're going to learn how to do this also. I've seen people do this anyway. It helps keep the catheter in place. Always make sure you secure your catheter because that'll tear right out. Infiltration is the biggest issue with local reactions. You won't necessarily see a patient have thrombophlebitis, but it's like an inflammation of the vein. Hematomas, if you missed and you need to, like, make sure you're putting enough pressure. Arterial punctures are relatively rare, but also possible. Again, if you have pulsating blood, that's an issue. Patients, there's a possibility of you hitting nerves, tendons, and ligaments in any area that you use for an IV site. But again, you want to make sure that whatever you're hitting is bouncy and not firm, because sometimes that firm is a tendon. Systemic problems that may arise from an IV, systemic allergic reactions, an air embolus if you don't do a good job. Catheter shear, this is why it's a one and done. You don't, like, try not to fiddle the catheter hub on the end of the needle, because the needle could slice off a little piece of that plastic and send it into the body. Patients might vasovagal themselves. You'll see this when you have patients who are in SVT. All right, I got to start an IV. And they're like, and like they're going to pass out, and they just fix their heart rate before you get the IV. Circulatory overload, right? If you put way too much fluid in that patient, just things to consider. Questions, thoughts, concerns. You're going to do a lot of this stuff in Skills Lab also. All right. We talked about this already, how the IO is very, very similar to an IV in terms of, like, the ability to infuse fluids and the same kind of rapid absorption. You might need a pressure infuser. If you don't have a pressure infuser, a manual BP cuff is very good at doing the same exact thing. The nice part about IOs is that even if the patient's, like, peripheral vasculature is collapsed because of serious shock or whatever, the bone is always going to be there, right? You aren't going to collapse a bone. Approved sites is your tibial tuberosity, the site you're going to learn during Skills Lab. The humerus, don't ask me where that is. I learned it once and I probably went, that seems challenging. And the sternum, which is not approved in our region, that you see that mostly in the military. They'll put the IO needle right in the sternum. That also requires a serious, a different size of needle. Most of the time we use IOs. We're using them in cardiac arrest. They could also be used in children because children are a hard IV stick. We talked about this, right? You want to make sure that that IO needle is inside the bone properly. If it's not, if you have like the bone's not, the fluid's not flowing, even with a pressure bag, and you have a, you know, the leg starts to swell up, it might, that needle's not there, it's no longer good. The bone can get inflamed or infected, osteomyelitis. We talked about that as well. If you're doing a pediatric and you don't IO and you don't put it in the right spot, you could damage the growth plate, so that kid's going to have one short little leg if they survive. Fractures in patients with really, you know, osteoarthritis and stuff like that. Pediatrics, you might go right through the vein, or the bone, which is also terrifying. And there's also the kind of vague possibility of a pulmonary embolism. Again, most of the time you're doing this on patients who are in cardiac arrest. So hopefully this isn't a concern, but you could send parts of the bone or marrow into the blood circulation and it ends up in their lungs. This is called osteogenesis imperfecta. You can't do an IO in a patient with osteogenesis imperfecta. Anyone see the movie Glass? Samuel L. Jackson? It wasn't a great movie, so I really don't expect you to necessarily have seen it.
Blasphemy. It was a good movie.
It wasn't a great movie. It was a good movie. It wasn't a great movie. It was Samuel L. Jackson, which is really why you're into really watching that, and Bruce Willis. Basically, the whole concept is he has osteogenesis imperfecta. The problem with this particular disease process is it's called fragile bone syndrome. Okay, so basically they will have very small injuries will cause the bones to break. Okay, so you know they clap too hard and they'll break a bone. Very, very fragile. Osteoporosis is another contraindication. But again, if you have a patient who's in cardiac arrest and you need a vascular access, that's kind of a relative contraindication. If you know they're a bad diabetic and you can't get an IV, that might be a more solid contraindication. Anyone with bilateral knee replacement site, we talked about that already. Any suspected fracture of the intended leg, either do the other leg or pick a different site. All right, two different types of medication administration. We have enteral, which is anything via the GI tract, mouth to anus. Okay, so rectal, oral, OG tube, gas G tube in general. Okay, right, is considered enteral. Okay, goes through first pass metabolism 90% of the time because rectal doesn't. Anything that is not going in the GI tract is considered parenteral administration. If you're having a hard time remembering this, enteric coated aspirin, enteral, okay? Just connect those two in your head. Parenteral is outside of that, sub-Q, IM, IVIO, transdermal patches, any of those things is considered parenteral. Or sorry, percutaneous.
Sublingual as well, right?
Sublingual and transdermal are considered percutaneous, but yes, they fall into the parenteral, that it's not inside the GI tract. And then we're just subclassifying it more. Percutaneous, right? It's going through the skin. The mucous membranes are considered skin. And then you also have inhalation. So, quick side note. I know in the textbook, it probably says that oral glucose is a buccal medication. It is not a buccal medication. It's an oral medication. The 1970s has done serious scientific research. Your cheeks, which is buccal, do not absorb glucose. There are parts of your tongue that do, but that's considered oral. I know we say, oh, put the glucose in between the patient's cheek or whatever. Not effective. They need to swallow the glucose in order for it to be effective. Most tests and stuff will still consider, on EMS tests, will call oral glucose buccal. Just know that if your patient cannot swallow, putting it in their cheek, not going to do anything. Okay. Yeah, that's on my list of things that annoy me. Endotracheal, very frequently not used. We talked about this already, right? Because it's unpredictable, you need to increase the dose. really only used in neonate resuscitation. These are the medications, your lean medications. In the event of cardiac arrest in the city, you can call, and actually I don't think you need to call, you can access a PIC line, okay? They're long-term devices. They're usually in the upper arm. They're surgically implanted. They go and they end up, they're embedded like about the heart. There is also lines that are PIC, like there's some PIC lines that don't go all the way up to the heart. They might just go into the vein. Those are patients who are receiving long-term antibiotics or some other medication like chemotherapy or something. You might have patients with implanted vascular devices. It's usually right here on the chest. It's a very small, it's usually called a button port. The button ports require a very special needle and very special training, because if you mess up that port, they need to replace it. Okay, so you are not to access a button port. AV fistulas, again, we are not approved to do AV fistulas. You can access a PIC line in the event of cardiac arrest as per protocol.
With PIC lines, are your doses the same that you would use for an IV?
Mhm.
It's all the same. You're not changing anything.
Yeah, it's all the same. It's just an embedded IV that you can access in cardiac arrest, because they're assuming like, hey, this is already there, may as well. You just need to make sure that it's not like a triple lumen. So if it has just one line, you're good to go. If it's got more than one line, the triple lumen, we can't access that without, I think, discretionary. You might need a discretionary order for that, because there's heparin in the catheter that keeps it going. So medications, it comes in a lot of different varieties, right? So you have your ampule. Norepinephrine is in an ampule. You have to be careful how you break that. You make sure. There's a really cool thing that you can break the top off an ampule and hold it upside down, and the medication won't come out because of surface tension. Fun little fact. You have regular single-use vials. You have single-use tubes. You have these like D50 and epinephrine and calcium, where you just screw it together into the shooter. You have solumedrol, where it's a single vial where you reconstitute the powder with this up top. Everyone's favorite medication to reconstitute. Glucagon for shelf stability. It comes powder and a reconstitution sterile water. Same concept, but now you need to, as the solumedrol, but now you need to draw this water up and then put it into the powder. Remember, you're putting the water in the powder, not the other way around. There's a medic student who was trying to draw the powder up into a syringe. Water into powder, mix, 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 then draw it up. You also have carpet jets. Some medications use this. There's some narcotics that are packaged like this. Some places have it, some places don't. Personally, I've always had an issue with carpet jets. I just, for some reason, can't put them together. Don't know why. Different angles that you're going to use to insert medications. First and foremost, you need to know intramusculars at a 90-degree angle. Okay, if you're coming straight in on that muscle, you're going to go all the way through the subcutaneous tissue into the muscle, right? There's a lot of tissue in between your skin and the muscle that you need to get that medication where it needs to be. Subcutaneous is at a 45-degree angle. Intradermal, right, your TB test is about 10 to 15. I know it says IV is about 25, but a lot of the time, especially if it's a very surface vein, you're going to be coming in at more of a 10 to 15 degree angle. Okay, you're going to be riding it right along the skin and into the vein. Again, you're going to do a lot of this in skills labs. You're going to do a lot of this on your rotations, and you're going to kind of figure out like what the perfect angle is for stuff. Because sometimes if you're coming in at a 25-degree angle, you're too high, you go right through the vein. Okay, so you want to slide that in. Slide into those IV DMs. IV boluses, okay? They come in a lot of different varieties. It could be it's usually a single dose medication, but it could be a drip. Okay, so you might that patient might be on that dose for a while. So either way, it's going to be if it's a bolus or a drip, it's a single dose. Every medication has its own particular speed by which it needs to be administered. For example, Amiodarone needs to be administered over 10 to 20 minutes when it's in a drip form. When it's in a IV bolus form for cardiac arrest, you just kind of put it to bed. You administer it and call it a day. Amiodarone burns in your conscious patient. That's why we do it. We dilute it and we give it to the patient over time. Always make sure that the port is clean before you connect the syringe to insert the medication. You see here, so here's your syringe that you're connecting to the port. Almost everything has a Lora lock these days, which reduces needles, which reduces needle sticks. You're going to have an IV bag. That IV bag you're going to clamp off, so you're just administering straight to the patient. As you administer this bolus, it sits in this tubing. It will not go to the patient until you flush it through. Okay, so just keep that in mind, because you see that you always have to follow up a bolus with a flush. That flush should be at, like, usually it's about 10 to 20 milliliters of saline. If you're administering an IV drip and you need to set it up, and you're all going to do this in the skills lab, you have the IV tubing port, which is the one where you pull the end off to insert the needle, the big plastic one, and then you have a medication port, which you're probably going to use a needle to insert. We have a few different drips that we use: amiodarone, mag, dopamine, Levophed. Not a huge amount of IV drips that we do in the field. Most of the stuff that we do are boluses because it's an emergency medication. Before you put the IV tubing into this bag, you need to make sure the medication is mixed in, because otherwise you've got 30 to 50 milliliters of IV tubing with no medication, and you're wasting time. So keep that in mind. Always, 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 always make sure that you label that medication. You're probably going to end up using medical tape to do so. Make sure it's labeled. I brought in a patient with a amiodarone drip going, was labeled. The nurse opened it up wide and just dumped amiodarone. I've seen patients get dopamine that was labeled with medical tape. Nurses open it up thinking it's just saline, and their pressure is like, well, we fixed the pressure. So just make sure it's labeled, and make sure that if you're going into like a trauma room or a notification room, everyone's aware of the fact that that is not just saline, okay? Medication errors, how we can avoid them. A lot of different factors can influence the rate of medication absorption. We've covered this. Moving on, and that's it. All right. Hi, Mike. Any questions?
Yeah, Nicole, could you just please, as soon as you get a chance, send us the blueprint?
I'm gonna send your blueprint with your homework assignment. No problem.
Word.
When's the homework due?
When's your next lecture? I don't even know off the top of my head.
Monday.
Monday?
Monday's next lecture.
Wait, what is Monday? Monday's online or in the classroom?
Monday is WebEx, and Monday I think is the protocol pharmacology lecture, maybe?
So before lecture on Monday, I want the homework. I'll send it out to you. I'll give you the due date. It will help you in understanding the Monday lecture as well. So it'll be a nice, smooth, and you'll be able to ask questions or have any questions that you might have answered.
I have another question. When we left lab the other day, Vinny was saying to start doing the drug cards, like that we should work on those. I went through the chapter, maybe, I don't know. I kind of just like skimmed through everything, but I never saw an actual list of like the medications like with that info. Where would we get that?
I think we're good. Yeah,
Maybe your homework.
I think the homework that she's sending us is going to do it.
Yep.
All right, see.
In the back of the textbook is all the medications with the contraindications, dosages, and how they're given. In the back.
Oh, okay. I looked through the two chapters and I didn't see it. I didn't
Yeah.
think to look at the back of the book.
I also, it's part of the directions for this homework, I want you to look at the protocols also. Probably one of the best formats that you're going to have for this is, I would say, set up an Excel sheet,
Mhm.
and you're going to do medication, route, dose, across the top, route, dose, indications, contraindications, and what protocol you find it in. So that's pretty much what the homework is.
Oh, that's cool. Oh, also, while I have everybody here real fast, little favor. You see Scott's been sending like these emails recently that are like, hey, respond in like 5 seconds or you're out of the program type of deal. I'm going out of town. I'm going backpacking up in Maine tomorrow, Friday, and Saturday. There's a chance that during that time, if my phone is out or whatever, if you see Scott send one of those emails out or whatever, text me or something, and if I don't respond to you, it means I didn't get it. Could somebody just like have my back on that?
Anthony, if you text me, if you direct message me your cell phone number, I'll take care of that.
All right, cool. Appreciate you.
All right. Any other thoughts, questions, or concerns? I'll send out the blueprint and the homework once we get off of here.
Is this quick question, Nicole? Is this all gonna be on one video or like
Yeah.
separate videos?
It's gonna be one
yeah,
video.
okay.
I've switched over to the WebEx. I'll have that hopefully posted by the end of the day.
Okay, cool. I found your lectures really helpful when I rewatched them. So
Oh, good, good.
yes.
I don't understand.
Oh wait, that's Google. Sorry.
Sorry, Google. I'm sorry you don't understand.
Yeah.
Very needy, that girl.
I don't know.
Google's also got to rewatch the lecture.
She doesn't really get it. So
All right, guys. I'm gonna stop recording now.